السلام عليكم ورحمة الله وبركاته. أعزائي طلبة المرحلة الخامسة في طب الأسنان، ألتقيكم مرة أخرى ومحاضرة جديدة من محاضرات مادة طب الفم، وعنوان المحاضرة Neuromuscular Diseases. أتمنى أن تستفيدوا منها. نبدي بسم الله الرحمن الرحيم. راح نتكلم على many types of neuromuscular diseases. نبدي بداية بالcerebrovascular disease. Cerebrovascular disease refers to disorders that result in damage to the cerebral blood vessel, leading to impaired cerebral circulation. Cerebrovascular accident or complete stroke is a sudden impairment in cerebral circulation resulting in death or a focal neurologic deficit lasting more than 24 hours. Transient ischemic attack, reversible acute short duration focal neurologic deficit, mini stroke resulting from transient and localized cerebral ischemia. Reversible ischemic neurological defect called RIND, reversible acute focal neurologic deficit due to transient and localized cerebral ischemia, but resulting in neurologic deficit that lasts more than 24 hours. Stroke in evolution, defined as a progressive worsening of stroke symptoms. Clinical manifestations, depending on the size and location of the affected brain region, the most common signs and symptoms include sensory and motor deficit, changes, varices in extraocular muscles and eye movements, visual defects, sudden headache, altered mental status, dizziness, nausea, seizures, impaired speech or hearing, and neurocognitive defects such as impaired memory, reasoning, and concentration. Three major types of ischemic stroke syndrome have been described. First, small vessel, which is lacunar. 2, large vessel, cerebral infarction. 3, brainstem stroke. So we have 3 types of ischemic stroke. Lacunar strokes result from obstruction of small, less than 5 mm diameter, penetrating arterioles. Symptoms usually include unilateral motor or sensory deficit without visual field changes or disturbances of consciousness or language. The prognosis for recovery from lacunar infarction is fair to good, with partial or complete resolution, usually occurring over 4 to 6 weeks. Cerebral infarction, large vessel, is characterized by extensive downstream ischemia, usually due to a thromboembolic event along the distribution of the internal carotid and cerebral arteries. High-level brain functions are affected and the prognosis is poor. Brainstem infarction results from occlusion of small or large vessels supplying the brainstem, resulting in variable deficit ranging from motor and sensory deficit to death when respiratory centers are affected. Diagnosis. We have important point in the diagnosis of patient of cerebrovascular disease include clinical manifestations, laboratory evaluation like complete blood count, urine analysis, coagulation profile, and blood culture, echocardiography, and lumbar puncture. Treatment. TIAs and RINs are treated by reduction in hypertension, that's to say lifestyle changes such as diet, smoking, exercise, smoking cessation, and stress reduction, medical therapy for hypertension, and anticoagulant or antiplatelet medications. The other disease is called multiple sclerosis. What is multiple sclerosis? Multiple sclerosis is neuromuscular disease characterized by multiple areas of central nervous system, white matter inflammation, demyelination, and gliosis or scarring. So we have three important characteristics in this patient or in patient with multiple sclerosis, which is white matter inflammation, demyelination, and scarring. Myelin is critical for propagation of nerve impulses, and when it is destroyed in MS, slowing and or complete block of impulse propagation are manifested by abnormal muscular and neurologic signs and symptoms. The clinical course of MS varies from a benign asymptomatic disease to a rapidly progressive and debilitating disorders. The two most common infectious agents to be implicated in the pathogenesis of this disease are Epstein-Barr virus and human herpes virus 6. So we have two viruses which are Epstein-Barr virus and human herpes virus 6. What is the lesion of MS called? Multiple sclerosis lesion is called plaque. Plaque vary in size and are characterized by perivenular cuffing with inflammatory mononuclear cells, predominantly macrophages and T cells, that is generally limited to the white matter and periventricular areas of the CNS. The major clinical type of MS that affects nearly 85% of those suffering from the disease is termed relapsing remitting multiple sclerosis. Relapsing remitting multiple sclerosis is characterized by discrete attacks that generally evolve over days to weeks and often follows with complete recovery from symptoms. Relapsing remitting multiple sclerosis may evolve into secondary progressive multiple sclerosis in approximately 50% of patients after 15 years. The clinical manifestation of patients with multiple sclerosis depend on the areas of the CNS involved, and frequently affected areas include the optic chiasm, brainstem, cerebellum, and the spinal cord. The sudden onset of optic neuritis, which refers to diminished visual acuity, dimness, or decreased color perception without any other CNS signs or symptoms, is often considered as the first symptoms of multiple sclerosis. Other signs include diplopia, blurring vision, nystagmus, gas disturbances, visual field defects, limb weakness, cerebral dysarthria, which is called scanning speech, bladder dysfunction and bowel dysfunction, sensory impairment, paresthesia and hyperesthesia, fatigue, depression, and cognitive dysfunction. How can make diagnosis to patient with multiple sclerosis? Regarding the diagnosis of the patients, clinical criteria for multiple sclerosis include 2 or more episodes of symptoms and 2 or more signs of pathology affecting white matter tracts of the CNS. MRI demonstrate characteristic abnormalities of MS in more than 95% of patients. MS plaques are visible as hyperintense focal areas. CSF analysis show positive findings include an increase in total protein and mononuclear white blood cells. Treatment of acute attack. Treatment include treatment of acute attacks, treatment that reduce the biologic activity of MS, asymptomatic therapy, and glucocorticoids. For oral health considerations, neuropathy of the maxillary and mandibular branch of the trigeminal nerve, which may include burning, tingling, and or reduced sensation. Neuropathy of the mental nerve can cause numbness of the lower lip and chin. Myokemia, facial weakness, and paralysis. The other disease we will talk about is Alzheimer's disease. Dementia is defined as an acquired deterioration in cognitive abilities that impair the successful performance of activities of daily living. Memory is the most common cognitive ability lost with dementia. Other mental faculties affected include problem-solving skills, judgment, visuospatial ability, and language. 2 forms of Alzheimer's disease are present, familial and sporadic forms. So we have 2 forms of the disease, familial and sporadic. Familial Alzheimer's disease is an autosomal dominant disorder with onset typically prior to the age of 65 years. Clinical manifestation. The clinical manifestation of Alzheimer's disease is a slowly progressive disorder represented by a continuum clinical characteristic. Updated clinical criteria recognizes the 3 stages of the disease. We have 3 stages of Alzheimer's disease. First, preclinical. Second, mild cognitive impairment due to Alzheimer's disease. And the third type or stage, dementia due to Alzheimer's disease. Preclinical Alzheimer's disease occurs before changes in cognition and everyday activities are observed and primarily used for research purposes. Cognitive impairment due to Alzheimer's disease is characterized by mild changes in memory and other cognitive abilities that are noticeable to patients and families, but are not sufficient to interfere with day-to-day activities. Dementia due to Alzheimer's disease is characterized by changes in two or more aspects of cognition and behavior that interfere with the ability to function in everyday life. The initial signs of Alzheimer's disease involve retrograde amnesia from progressive decline in episodic memory. This may initially go unrecognized or be viewed. However, as the disease progresses, memory loss begins to affect performance of daily activities, including following instructions, driving, and normal decision making. Advanced Alzheimer's disease is characterized by loss of cognitive abilities, agitation, delusion, and psychotic behavior. Patients may develop muscle rigidity associated with gait disturbances and often wander aimlessly. In end-stage Alzheimer's disease, patients often become rigid, mute, incontinent, and bedridden. Help is needed for basic function such as eating, dressing, and patient may experience generalized seizure activity. Death often result from malnutrition, heart disease, pulmonary emboli, or secondary infections. For the diagnosis of patient of Alzheimer's disease, biomarkers assessment, we have many steps for the diagnosis. From these steps, biomarker assessment, including markers of apoprotein deposition in the brain and markers of downstream neurodegeneration, which mean elevated CSF fluid, tau protein, and brain atrophy on MRI. Clinical diagnosis of Alzheimer's disease is based on an individual's medical history together with the clinical and neurologic examination findings. For the treatment of the patient of Alzheimer's disease, there is no cure for Alzheimer's disease, and therapy is aimed at slowing the progression of the disease. Cholinesterase inhibitors are approved to treat mild to moderate cases of Alzheimer's disease and are considered the standard of care. The other disease we will talk about is seizure disorders. So what we mean by seizure? Seizure is a paroxysmal event due to abnormal excessive electric discharge from neural aggregation in the CNS. The term epilepsy describes a condition in which a person has recurrent seizures due to a chronic underlying process. We have two types of epilepsy, partial and generalized type. Partial seizure, in which seizure activity is restricted to focal areas of the cerebral cortex. Clinical manifestations depend on the site of origin. The other type is generalized seizure, in which the seizure arises from both cerebral hemisphere simultaneously and have distinctive clinical features that facilitate diagnosis. The diagnosis of the patients include A complete neurologic examination is required for all patients with suspected seizures activity, including testing of cranial nerve function, assessment of mental status, and testing of motor function. Blood studies in which complete blood count, electrolyte glucose, magnesium and calcium to identify metabolic cause of seizure activity. Other useful screening tests include toxin screens to identify seizure activity due to drugs and lumbar puncture to rule out any infectious etiologies. Treatment. The treatment, we have many drugs used for treatment of patients with Alzheimer's disease or for the seizure include lamotrigine, carbamazepine, or phenytoin is currently the initial drug of choice for the treatment of partial seizures, including those that secondary generalize. Phenytoin is associated with gingival hyperplasia, hirsutism, and coarsening of facial features. Carbamazepine, the other drug is carbamazepine, which can cause hepatotoxicity, leukopenia, and aplastic anemia, whereas lamotrigine has been associated with skin rash. Patients with poorly controlled disease or stress-induced seizures may require sedative medications prior to treatment. This should be determined in consultation with the patient's physician. To minimize the risk of injury and aspiration during dental treatment, use of dental floss, secured mouth probe, which are easily retrievable, and a rubber dam is recommended. Placement of metal fixed prosthesis is recommended rather than removable prosthesis to decrease the risk of displacement and aspiration risk during seizure activity. The other disease related to neuromuscular disease is Parkinson's disease, which is a chronic progressive neurodegenerative disorder characterized by resting tremor, cogwheel rigidity, and bradykinesia, which mean slow intentional movements. Secondary symptoms include change in speech, difficulty in swallowing, pain, confusion, depression, fatigue and constipation, postural instability, develop in later stage of the illness. Parkinson's disease results from idiopathic degeneration of the dopaminergic cells in the pars compacta of the substantia nigra, leading to depletion of the neurotransmitter dopamine in the basal ganglia. Both of genetic and environmental factors regarding the cause of Parkinson's disease have been suggested. Clinical manifestation. Resting tremors in hands, arm, leg, jaw, and face. Rigidity or stiffness in limbs and trunk. Bradykinesia refers to slow of movement, and postural instability or impaired balance and coordination. As symptoms become more pronounced, patients may have difficulty in walking, talking, or complete other simple tasks. Treatment of the patients with Parkinson's disease include, or there is no cure for Parkinson's disease, but a variety of medications and procedures provide dramatic relief from the symptoms. The most common pharmacologic treatment is dopamine replacement therapy. The other disease we will talk about is myasthenia gravis, which refers to chronic neuromuscular disease caused by autoimmune destruction of the acetylcholine receptor, disrupting cholinergic neuromuscular neurotransmission. Clinical manifestations: 2/3 of patients with myasthenia gravis present with complaint of specific muscle weakness in the eye with associated diplopia and or dropping eyelids, oropharyngeal muscle weakness, difficulty in chewing, swallowing, or talking. After 10 to 15 years of fluctuating disease activity, weakness often becomes more fixed and associated with muscle disease, disuse, atrophy. Factors that worsen myasthenia gravis symptoms include stress, systemic illness, especially viral respiratory infections, hypothyroidism or hyperthyroidism, pregnancy, and menses. For the diagnosis, serologic evidence of autoantibodies to the acetylcholinesterase receptor, although there are reports of myasthenia gravis without anti-acetylcholinesterase receptor, CT or MRI of the chest is highly accurate in detecting thymoma, and every patient with myasthenia gravis should be screened for thymoma. For treatment, acetylcholinesterase drugs such as nistagmine and pyridostigmine bromide increase acetylcholine availability and receptor binding and provide asymptomatic benefit without influencing the course of the disease, reducing autoantibody production using corticosteroids, oral or IV plus IV. Also, plasmapheresis to remove autoantibodies and high-dose intravenous immunoglobulin. بهذا القدر نكون قد انتهينا من محاضرتنا اللي كانت بعنوان Neuromuscular disease. أتمنى أن ألتقي بكم في محاضرة أخرى من سلسلة محاضرات طب الفم، وأشكر إصغائكم والسلام عليكم ورحمة الله وبركاته.